Thank you very much. Good morning. Salam to everyone. So this will be my second year in a row discussing about management of gallstones. It is important topic because there are so many patients that present to general practice clinic with symptoms which is caused by gallstones. But there are also differential diagnosis to the gallstones. So I try to emphasize how to differentiate between the symptoms caused by gallstones and symptoms caused by other important causes in our medical practice. The true incidence of gallstones is unknown. It's very difficult to get the statistics of patients or people that have inactive pathology unless the government embark on a very expensive general screening. Most patients are asymptomatic from the available statistics that obtained from ultrasound being done on patients who are referred for ultrasound but having different symptoms, different pathology, but they incidentally discovered to have a gallstone. And most of the patients, people with gallstones are asymptomatic, ranging from 50% to 70%. In the American data, there are about 10% of American population who harbors gallstones. And in Western countries, about 5 to 20%. What is the data in Malaysia? I would imagine it's between 5 to 20% too. And it is well known that the incidence of gallstone is more among women than men, to the ratio of up to 4:1. So you will see more female patients presenting with symptoms caused by gallstones. So in the American statistics, there are about 1 million annual hospitalization with the diagnosis caused by gallstones, and that is translated into 500,000 cholecystectomy. That's a lot of operations, even for a large country like America, amounting to about $2 billion per year of healthcare finances. More than 70 years old patients or people will harbor gallstones in 50% of women and 16% of men. But as they grow older, in the 90s, 80% of people will have gallstones. What are the risk factors for gallstone formations? In general, if you look at the list of the factors, you can classify them into two groups. One is a modifiable group, and the other one is unmodifiable group. Of course, our interest is in the modifiable group, which we can intervene to either treat the patient or prevent the gallstone formation. But we also need to know the unmodifiable group, which can illuminate the patient's knowledge regarding gallstones. Of course, obesity is the main epidemic all around the world during this modern lifestyle with the modern diet, not only in the West, but also in Malaysia now. In fact, there is a statistic saying that Malaysia is the most obese country in Asia or in Southeast Asia. So it's not surprising if you look at the social media or even on TV, the culinary program is very highly rated. So obesity is one of the causes of gallstones, but opposite to that, weight loss. Of course, we need to ask the patient to lose weight, but rapid weight loss is also a cause of gallstone formation, especially with the advent of bariatric surgery. It has caught on to some Malaysian surgeons who take up doing bariatric surgery to treat patients who want to lose their weight drastically, but it is statistically proven that this surgery is one of the causes of gallstone formation. Of course, there are other causes, female unmodifiable cause. I mean, because of the hormones and genetics. So female are predisposed to develop gallstone more than men. Pregnancy, you can debate whether this is modifiable or unmodifiable factors, but it is a well-known factor to develop gallstones. Some common drugs, ethnicity, the most common among the American Indians and also Scandinavians. Heredity, there's many patients who presented with gallstone who also have a first-degree relative that suffered from gallstone. So this is well documented. And in Malaysia, hemolytic disease is one of the common factors that cause gallstones. Allele disease, major resections, especially in patients with malignancy or even trauma, if there was resection of ileum more than 50 centimeters from the ileocecal junction, and this group of patients are susceptible to develop gallstone as a long-term sequelae. Inflammatory bowel disease is not that common in Malaysia, but they do happen. For long length Crohn's disease, they can develop gallstone because of that. And elderly, as I mentioned earlier, in patients more than 90 years old, 80% of them will have gallstones. So some gallstones, in fact, most gallstones are silent, but some do give symptoms. We have revised our biliary anatomy with Dr. Fatima just now. It is good to revise this biliary anatomy because I would imagine most of us that are not surgeons, the last time, if we ever saw any real life gallbladder was when we were medical students or even when we were doing our junior training as housemen or MO, assisting surgeons. And apart from that, gallstone remain elusive from our imagination. So revising this anatomy is good because it is relevant when we see patients on a daily basis. So I like this diagram very much because clinically it really oriented our view of the patient surface with the deep anatomy. And you can sometimes we lose sight of the fact that there is a diaphragm separating the thorax from the abdomen, and gallbladder and the biliary structures are infradiaphragmatic, but the adjacent organs, which is lung and the heart, is supradiaphragmatic, but they are in close vicinity. And when there is a disease process causing symptoms, they manifest to the surface sometimes quite vaguely, and patients couldn't really point exactly whether it is the abdomen, in the upper abdomen, or in low thorax. So bearing in mind of this anatomy is good to differentiate the possible diagnosis. And when we talk about gallstones, our anatomy of interest is really extrahepatic biliary system. You can imagine there is a capsule on the liver here, which is a border between the intrahepatic bile ducts and the extrahepatic bile ducts. And the extrahepatic bile duct will start from the what we call a bifurcation. This is a right intrahepatic duct and left intrahepatic duct, and they come down, they join up, and we call it a bifurcation. And from this point of bifurcation to another junction, this is a junction of the cystic duct, which join the gallbladder to the bile duct. The whole length from the bifurcation to the papilla is bile duct. And these bile ducts are separated into two components. One is a common hepatic duct between the bifurcation and the junction of the cystic duct. And the other is common bile duct. Common bile duct is from the junction of the cystic duct to the papilla. I know this is the accurate anatomical description and nomenclature, because we as clinicians sometimes we forgot to use the proper anatomic term, and sometimes can cause some miscommunication between surgeons, radiologists, doctors, So sometimes when the radiologist say common bile duct, it means the whole thing. But to the surgeon, common bile duct is from the cystic duct to the papilla. And this shorter common hepatic duct is between the hilum and the junction of the common bile duct. What is the theory behind the formation of gallstones? These are conventional theories in the surgical textbook when we were medical students, and over the years they have developed from it, but the conventional theory remains. These are the four main theory of gallstone formation: cholesterol supersaturation, imbalance between the cholesterol and the bile. These are two chemical components in the bile fluid, which come from the liver down to the bile ducts and stored in the gallbladder. Is the main chemical component of those bile are cholesterol and bile acids. And it is theorized that there is imbalance of more cholesterol, or in terms of percentages, the more cholesterol than the bile acids that start the formation of gallstones. And there are other factors as well, which contribute to the formation of gallstones. And for the pigmented stones, the excess bilirubin are due to the red blood cell breakdown. The new pathogenesis theories developed by researchers of late, since the Human Genome Project, where they identified so many genes for so many normal conditions plus pathologic conditions. And for the gallbladder stones, they have identified some genomes that are more often occurred in some patients with gallstone, not all patients. So this remain a theory rather than an absolute predisposing factors to the gallstone formation. And for most hemolytic disease, they are immune-related and hereditary in nature, especially thalassemia, which is very common in Malaysia. And it's also new theory blaming the altered gut microbiota as one of the factors predisposing to gallstone formation. These are all theoretical and active research topics in academia. In general, gallstones are of three types physically. First is a cholesterol stone. This is the most type of stones, which consists of, which contribute to 80% of the cases of patients with gallstones. And their appearance usually whitish or grayish in color. I'll show some sample afterwards. Since this is a surgical lecture, we have to show some surgical specimen, even if it is just a lifeless stone. And chemically, it has more than 50% cholesterol in the cholesterol stones. Second type is mixed stones. Mixed stones are usually described as yellowish in color and physical appearance. And the cholesterol components are less. They range from 20 to 50% cholesterol. And the third gallstone types is the pigmented stones. This has the least amount of cholesterol in it, less than 20%. And pigmented stones contribute to 80% of the gallstones patients. So cholesterol is 80%, pigmented stone is 20%. So what happened to the mixed stones? You can imagine the mixed stone will take up some of this 80%, some of this 20%, because this classification is a watershed. Sometimes we just lump them into cholesterol stones, sometimes we lump them into pigmented stones. And the pigmented stones are usually black and brown in color. And the most important chemical component is the byproduct of hemoglobin metabolism, which is the bilirubin. Okay, these are some real samples of my cases over the years. I tried to get some representative type of stones, but this is what I managed to get from the thousands of pictures on the desktop. Anyway, if you can appreciate, this is yellow in appearance, but the fact that it is quite geometric in nature. Usually cholesterol stones are very geometric in nature, very smooth surface, and you can see the angle very nicely. But this appears to be yellow in color, so you can see is this a cholesterol stone or is this a mixed stone? Sometimes it's classified together. So that's why there is no percentage of mixed stones, because they can go either way. And then you can see this stone. You can see some whitishness over here. These are basically mud or sludge covering the stone. So this is probably cholesterol stones covered by sludge. And you can see this rough surface of stone as well. So stones come in various shapes and forms and types and color. Okay, let's get clear with the definition, because we are communicating between surgeons and general practitioner and also radiologists and sometimes pathologists as well. So these definitions are basically standardized in the textbook, in the literature, but sometimes in our day-to-day practice, we seldom revise them, and we use what is commonly used and what is comfortable with us. So we use the term interchangeably and with a meaning only known to us sometimes. Okay, what is gallstones? So sometimes the gallstone is equal to gallbladder stones, equal to cholelithiasis. So it's basically cholelithiasis is just gallstones. And we have mentioned just now, 70% of them are asymptomatic. So gallstone per se is not a clinically important problem as far as a doctor is concerned, or even as far as patient is concerned. They are important only when they manifest as a clinical problem. We will discuss further on that. So gallstones that are discovered on ultrasound are usually large stones. Stones that are seen on ultrasound are usually large. Maybe the radiologist can enlighten on us on the minimum size of stone they can discover on ultrasound. But I would imagine if it goes below 1 millimeter or less, you can hardly see the stone, and sometimes the diagnosis of cholecystitis is made as acalculous cholecystitis, but there could be a small stone lingering in the form of microscopic stone. This is well established in surgical and pathology textbook. The concept of microscopic stone or microscopic crystals, or the other term is microlithiasis. And then there is a term sludge. Okay, we heard about the sludge in radiology just now. It's basically amorphous structures, but chemically it contains all these crystals, including the cholesterol crystals. So this cholesterol crystals is basically a microscopic crystal, microlithiasis of the early cholesterol stone formation. So as far as surgeon is concerned, when we see the report on ultrasound as sludge, we will equate it to microlithiasis, because there is almost always microcrystal within the sludge. So it is not a minor thing as far as patient is concerned when their clinical diagnosis is cholecystitis and there is sludge inside there. To the surgeon, it is acute calculous cholecystitis, although there is no large stone, it's merely a sludge inside there. So sludge, a microcrystal, they always proceed stone formation. See this a logarithm. So when there is a macroscopic stone and when there is a microscopic stone, they will always develop into a macroscopic stone. So when we see a sludge or microscopic crystals and patient has got cholecystitis, we will never wait for a macroscopic demonstration on any imaging to manage the patient as calculous cholecystitis. Choledocholithiasis, this is basically gallstones in the extrahepatic duct. All the choledochor basically means bile duct, but this could be stone in the common bile duct. You know, we divide the bile duct into two portions now, or it could be a stone in the common hepatic duct. Okay, some clinical terminologies. Biliary colic. We make this diagnosis very often when we see patient. We send a referral to surgeon, to radiologist. So it's basically a crampy, colicky abdominal pain, okay, caused by gallstones or any other obstructive lesion. We heard just now, polyps can cause biliary colic too, or even gallbladder carcinoma can present with merely biliary colic without evidence of acute cholecystitis. When there is a cholecystitis, there's already inflammation in the wall, as demonstrated by ultrasound to be a thickened gallbladder wall. In a patient with mere biliary colic without acute cholecystitis, ultrasound usually shows a normal gallbladder wall. So in acute cholecystitis, there is initial inflammation, which is usually caused by chemical alteration, ischemia, and then it progresses to infection when bacteria start colonizing the blocked gallbladder. And then acute cholecystitis can be divided into two. One is real calculus cholecystitis, and you can have acalculous cholecystitis. This is the controversial point that I mentioned just now. Is it true acalculous cholecystitis or microcalculous cholecystitis? We mentioned a bit further later. Acute cholangitis. Acute cholangitis is infection of the bile ducts. It's basically an ascending infection of the bile duct, which consists of common bile duct and common hepatic duct I mentioned just now. And you can imagine this bile duct system, they are in direct communication with the gallbladder and direct communication with the intrahepatic ducts, and the intrahepatic duct is direct communication with the liver. So acute ascending cholangitis is a potentially lethal, if not fatal condition, because uncontrolled infection will give rise to infection in the liver, which easily communicate with the portosystemic circulation and give rise to bacteremia and septicemia very quickly. So this is really a life-threatening condition. And if we discover that in the clinic, this is an emergency case to be referred to the hospital department. Okay, just to demonstrate how our understanding of the anatomy and the pathology can help with our clinical diagnosis. So when the stone is formed from the theory that we mentioned just now, they will start forming inside the gallbladder fundus body, from a small structure, and then they develop into big structure, and then from one develop into many. There's active research going on, in this process, how the nidus of a crystal can form into a big stone. So you can imagine every time we eat, if you recollect your physiology of digestion, whenever food enters the stomach, especially the pylorus, there is endocrine, neuroendocrine axis triggering a hormone of cholecystokinin that would contract the gallbladder. So if you can imagine, there is a stone floating inside the gallbladder here, and when there is, why is it contracting? Because the body is sending messages to the gallbladder, which is storing the bile, which contains bile acids and all the enzymes necessary for the digestion. But when the gallbladder contracts to squirt the bile, there's also stones inside there. And this stone will be pushed as well. And you can imagine, this cystic duct, the channel of the cystic duct is very small. In fact, in real life anatomy, it is not exactly an open channel. It is only a potential channel. It will opens up because there's a valve there. It will opens up only when there's a differential in pressure. So when the gallbladder wall contracts, it will push the bile, and the channel of the cystic duct will open up, and then the bile will come down the duct system into the duodenum for digestion. But with the stone floating around here, the gallbladder will also push the stone. And this is the beginning of the symptomatic problem. The gallstone will get stuck at the neck. Quite often, patient, when you make a diagnosis of gallstone, on ultrasound especially, the patient will ask you, how big is it, doctor? See, this is a myth which we have to dispel. One of them in the gallbladder myth. There are a few myths we will discuss later. One of them is the size of the stone. To the patient, which is quite a common sense myth actually. The small is less dangerous than the big. There is a common sense understanding of lay people, or even us, for anything in life. Small is less, big is more. Small is less dangerous, big is more dangerous. So when you diagnose a gallstone, the next question they will ask, how big is it, doctor? And then you will tell them it's 1 millimeter or 2 millimeter. Or sometimes you tell them, oh, you got a big stone, you got 2 centimeter stone. So the patient will be more scared when he has a 2 centimeter stone as compared to a 2 millimeter stone. But a doctor should be more scared when there is a small stone discovered. Because you can imagine, if it is a big stone, it will get stuck in the neck, and it will cause the typical progression from biliary colic. You know, when the stone gets stuck in the neck here, there will be a back pressure onto the wall of the gallbladder. And because of this, through the vagus nerve modulation, you will get a right hypochondriac pain and then radiated to the back. A typical biliary colic, okay? But if there is a small stone, you can imagine some of the small stone can be pushed by the gallbladder straight through the cystic duct into the bile duct. And you can imagine this stone in the bile duct is a precursor to acute cholangitis that we discussed just now. Okay, these are the 3 common conditions in my view that doctors always see when patients come and present with upper abdominal pain or right hypochondrial pain, and sometimes there's the area of the upper abdomen is not pointed very well in whether it is right hypochondrium or it is epigastrium or left hypochondrium. So basically, you have to entertain these 3 common clinical conditions, significant condition. I group them into these 3. Actually, there are many more. In fact, the other specific diagnosis I group as dyspepsia. Is basically all other abdominal conditions that are not caused by gallstone. So basically, there are 3 main group of clinical conditions that you have to entertain when there is upper abdominal pain or right hypochondriac pain. But there's some factors that we can identify that can direct us to one or the other diagnosis. For biliary colic, there is a dominant association with food. Patient with other non-biliary condition may have association or may not have, but usually the cardiac condition, they are not associated with food. And the quality of this pain, the types of pain, usually the biliary colic is crampy in nature. The dyspepsia usually more vague. They couldn't exactly describe. They can tell you that it is bloated, distended, and then angin and chucho and all those vague description. But in patient with cardiac condition, there could be tightness of the upper abdomen. And then the intensity of pain. Biliary colic is very intense, and patient can be crawling and rolling around because of pain and sweating. For the dyspepsia, the intensity of pain is much less. And for cardiac pain, there's a variable intensity. And one peculiar relationship is association with physical activity, exertion. And if there is upper abdominal pain with exertion, it has to be a cardiac condition rather than the other two. And then there's a very simple test to differentiate between the three. I put these three important tests because the first two now in most general practice clinic are easily accessible. And some general practice clinic, some hybrid clinic, this is controversial. Some hybrid clinic where specialists also practice as a general practitioner, they do have endoscope in their clinic setup. So we can use either of these tests or both or all of these tests to make one or the other diagnosis above. So I just want to present some of the representative cases that can demonstrate this these three common diagnoses. First, 40-year-old female, obese patient, severe colicky right hypochondrial pain radiated to the back, related to food. This is typical biliary colic. Now, on examination, patient is very distressed, but unremarkable otherwise. But don't forget the other two differential diagnoses as well. But you have to think of biliary colic as number one. Second scenario, younger man, male, smoker, and complain of generalized abdominal discomfort, bloatedness, and some constipation. On examination is basically unremarkable, no physical signs at all. And this one you consider is as dyspepsia as number one. But don't forget the other two differential as well in working up for the diagnosis. A third case scenario, a 60-year-old male, diabetes, hypertension, presented with upper abdominal pain, compressing, associated with exertion. And then on physical examination, there is hypertension. So you have to think of a cardiac case as number one, but don't forget the other differential as well. So you will do the basic examination, and then the two tests that you can do, ECG and ultrasound, immediately to get one or the other diagnosis. If it turned out to be negative on ultrasound, on ECG, and you suspect dyspepsia as number one, as in case in number two, you can start empirical treatment first. And if they start coming to you once or twice, they need to be referred for endoscopy. Is there wisdom in differentiating between biliary colic and acute cholecystitis? I think there is, because both of these conditions can be managed as outpatient by a primary care doctor, but with some alteration in medication. So differentiating the two, I think, is useful. What are they? So both, in fact, these are all characteristic of pain for biliary colic and acute cholecystitis. Basically, acute cholecystitis is a progression from biliary colic, if we can recall the anatomy diagram just now. Both presented with right hypochondrial pain in the upper abdomen, but the radiation of pain is usually with biliary colic, more so than with acute cholecystitis. And the intensity of pain usually in biliary colic because of the intense pressure of the wall against a block system. Whereas acute cholecystitis, the pressure is less, it's more of inflammation on the wall. The quality of pain. So the colicky crampy pain is more prominent in the biliary colic as compared to sharp pain in acute cholecystitis. And the duration of pain in biliary colic is few hours, but acute cholecystitis you get longer, sometimes days. And the most important clinical finding to differentiate between the two is the tenderness in the right hypochondrium, the typical classic signs of Murphy. Okay, it's basically tenderness in the right hypochondrium in the gallbladder area. When you ask a patient to take a deep breath and there is a catch in the breath. This is a typical description of Murphy's sign. And you don't get that in simple early biliary colic. So you can make a diagnosis of acute biliary colic or acute cholecystitis. You know, even if you want to refer to a surgeon, you can make this accurate diagnosis. Sometimes we get the diagnosis of acute gallstones. You know, if we get the nomenclature right, we can use the appropriate terminology descriptions. Why do we talk about conservative management of non-complicated symptomatic gallstone? So what is non-complicated symptomatic gallstone? It's basically biliary colic and early acute cholecystitis. This is because of in the literature, if we read the surgical literature or any general medical literature, what is the standard treatment for symptomatic gallstones? It is a gold standard treatment is cholecystectomy. This is the standard teaching. Currently, any symptomatic gallstones, the gold standard treatment is cholecystectomy, particularly laparoscopic cholecystectomy. But in real practice, we don't immediately operate on this patient, and some patients refuse operation. What do we do with them? And clinicians, especially surgeons, we are more pragmatic than some people. So we just cannot send them away and and ask them to sign EOR discharge and forget about it, because in this early symptomatic gallstone, the non-complicated one, patients are not very ill, and we know the disease process is not very advanced, and they are amenable to conservative treatment. Because when patient refuse cholecystectomy, we don't just discharge the patient. We continue with what do? We give antibiotics, we give painkiller, and we monitor the patient in the ward. And a large percentage of them recover from this conservative treatment, and that vindicate their refusal to surgery. So they will ask for discharge, and some of them you will never see them again. And some of them come back and agree for operation. And some patients are unfit for surgery. We are not going to do cholecystectomy on a patient with heart failure and ejection fraction of less than 20 and presented with acute cholecystitis. We will manage them conservatively. And if we can manage conservatively in a patient like that, we can manage conservatively in any patient. So this pragmatic experience have given rise to the idea that there is a role of conservative management in non-complicated symptomatic gallstones. But having said that, this is a research idea, because the current gold standard is still cholecystectomy. So one can read reports, case series in the literature, in the current literature, of the success of management of non-complicated symptomatic gallstones, i.e. biliary colic and early acute cholecystitis. Having said that, it is well known that these patients that undergo conservative therapy, 25% of them progress to complicated symptoms. Okay, meaning that quite a large portion of them do not need any surgery over a period of time. But these are all new ideas, and if you are a staunch academic, you need a randomized controlled trial to really shift from the idea of doing surgery on all symptomatic patients rather than giving conservative treatment. So these patients that are successfully treated in the hospital with medication, they will come back to see their family doctor in the clinic. So what do you do? So you should have the same idea as pragmatic surgeon in the hospital. We have to continue managing them because they refuse surgery or they are unfit for surgery. So we give antibiotics for short course antibiotics, 1 week, 5 days, 1 week. And then in order to control symptom, we know the gallbladder is responsive to especially fatty meals. So we ask patients to avoid fatty meals. Many of my patients, when they opt for conservative treatment of their symptomatic gallstone, they ask me, what do they need to avoid? I just told them they just need to avoid milk, oil, and any fatty stuff. In the end, they have discovered the only meal they can eat is singgang ikan and rice. And they can live on that for months. And they lose a lot of weight by sticking to that meals. So they lose weight and they control their gallstone symptoms. Antispasmodic, yes, can give antispasmodic to control any pain if they get pain during the conservative management. Painkillers, this is controversial. Remember, patients who are symptomatic, who are treated conservatively, they have a potential, I mentioned just now, 25% potential to progress further to develop a complicated symptomatic gallstones. So if we give a painkiller, this will mask any progression in their symptoms. So we have to avoid painkillers, just like when the young doctors working in accident and emergency, whenever patient come in with acute abdominal pain, we always say that the first thing you shouldn't do is to give painkillers to this kind of patient, because this will mask our diagnosis of any serious abdominal conditions. So too in this group of patients that you are managing conservatively for their early symptomatic gallstone, avoid painkillers like NSAID or opiates. You can give antispasmodic painkiller because this will not mask any serious inflammatory condition. This will help the biliary colic when they get an attack. You can give the well-known gallstone dissolvers in the form of Roacol or Ursofoc. It's all available in the market, in the pharmacy, over the counter, I think. You can buy them. And then you have to follow up this patient. This patient under conservative management, and even if they have recovered fully, you have to follow them up. Some doctors just told the patient to come back when you develop further symptoms. Symptoms are very subjective. Some of them, especially diabetic, they don't have much symptoms, but they can progress to further complication of their gallstone disease without knowing it. So regular scheduled follow-up is important for this group of patients, I think, so that you can discover further symptoms and signs in a timely manner. If they continue to have persistent pain, however low grade the pain is, this may indicate that the gallstone is getting more complex, and the other more serious symptoms will be and signs will be fever, obstructive jaundice. When I say obstructive jaundice, is basically a triad of jaundice, and tea-colored urine, and pale stool. And then there's tender abdomen with peritoneism. All these patients will indicate, all these signs and symptoms will indicate a complicated gallstone disease. What are they? So all these conditions are a progression from the simple biliary colic and early cholecystitis. They will progress to acute and serious one is emphysema of the gallbladder, will basically pass inside the gallbladder, or they can just develop chronic inflammation and further down the list. And the worst will be acute pancreatitis when the small stone get dislodged at the papilla. So just remind us on the pathophysiology of the complicated gallstone. When the stone are pushed down here, all those syndromes that I developed can easily happen and be imagined. When the stone are stuck in, you can see there is a confluence between the bile duct and the pancreatic duct, which is called common channel. And when the stone gets stuck here, it will cause acute pancreatitis. And some patients will get both acute pancreatitis and acute cholangitis, because they are all in the same systems. And some patients will continue to have their cholecystitis. So these are very ill patients when they have acute cholecystitis, acute cholangitis, acute pancreatitis, which a surgeon call pan-biliary sepsis. These patients are usually managed in ICU, and we have to intervene as fast as possible. I just want to show this table so that we can really appreciate the link between the gallstones and the syndromes it causes. This is a typical example of pathology. Gallstone is definitely a pathological state. But there are so many pathological states in patients that do not have clinical significance. They do not manifest clinically. They exist only as a silent pathological state. And one of them is gallstones. You know, if they are small, or even if they are big, and they don't cause the blockage in the neck, and they just floating around in the gallbladder every time a person take their meal, they will not cause any clinical condition. But once they get stuck in the neck, or they start travel down the biliary system, this is where there's a progression of a simple gallstone into the clinical syndrome. You know, we have described in the diagrammatic fashion just now, but now I just want to describe it in a table form so that we can see where all these relationships are. And I include here asymptomatic subclinical gallstone as one of the uncomplicated gallstones. This is all a theoretical concept in our mind. We may not see this group of patients because they are asymptomatic. We usually see biliary colic and acute cholecystitis patients. So these are early stage, if you can call it stage. There's no staging system in gallstone syndrome, but you can tell it to your own mind. This early stage. And patient might ask you, doctor, is this early stage? Doctor, the patient do not distinguish whether it is malignant condition or benign condition in order to ask what stage they are in. They might ask you what stage they are in. You can say this is an early stage, and we can manage you in the clinic without referring to the hospital. So once you refer to the hospital, you can do a few things before patient really go to the hospital. I see quite often patients are kept nearby mouth. No, in a patient with gallstone, whatever syndromes they have, they can still take clear fluids. It will not impact so much of the symptoms, because the biliary system will respond to food material like lipids and carbohydrates. So patient can continue to take clear fluids. And this clear fluid is not merely just mineral water. They can take isotonic drink or even Coke if they like it. It can give some energy. Just avoid milk and similar products. Continue taking their own medication. Whatever they're taking antihypertensive, they should take. You have to stop some medication like anti-diabetic, since they are not taking any glucose in, so they have to stop their anti-diabetic treatment. And if they are on blood thinners, many patients are on blood thinners because of the ischemic heart disease. You have to stop them immediately before going to the hospital. And then you can give them painkillers in the form of antispasmodic in the clinic before going out to the hospital, and even PPI, or even oral antibiotics that they were taking. They can continue taking them on the way to the hospital. Just avoid a stronger parenteral painkiller like opiates and NSAID. This is what we do in the hospital when the complex gallstone patient are admitted from the clinic. You can see this is a very highly intensive, highly resource management of this patient, befitting only a tertiary center actually. But in some secondary setup like our place, when there are multiple specialties that are helping one another in managing this complex patient, we can manage this patient, but it is a very stressful, labor intensive. You can imagine to manage this kind of patient in the tertiary center setup. There are rank and file of doctors from housemen, medical officers, registrars, and consultants. But in the private setup, you can imagine the consultant will function as a registrar, as a medical officer, as a houseman even. So that's why many general surgeons stop doing cholecystectomies in the secondary specialist hospital setup because of this intensity of resource required. Surgical treatment is quite straightforward actually. Surgically, basically, we have two problems to the surgeon. If it is complicated merely in the gallbladder, we just have to focus on the gallbladder by removing the gallbladder. If the patient is very ill, we cannot remove the gallbladder under general anesthesia. We will do percutaneous cholecystostomy to decompress the system first. If there is a stone and infection in the biliary tree, we will do ERCP and stenting to clear up the biliary tree before proceeding to the cholecystectomy. And the gold standard for any cholecystectomy is laparoscopic cholecystectomy. I know some surgeons will forget about laparoscopic cholecystectomy because patient is ill and high risk for complication and things, and it's easier to do open cholecystectomy. But I'm very pragmatic. If the anesthetist still say that the patient can undergo laparoscopic procedure, I'll still start with laparoscopic cholecystectomy before proceeding to open. Okay, there are recent few cases I just would like to share with participants, just to demonstrate that the gallbladder disease, gallstone disease, referred to the hospital can be challenging and tricky. Case number 1, 60-year-old male patient with a background history of hypertension, presented with 1 week history of severe upper abdominal pain, tender in the right hypochondrium with a palpable mass, and there's also fever and mild jaundice. And ultrasound and CT scan confirm there is empyema of the gallbladder. But other workup shows that the patient is septicemic, there is acute renal injury, and there's also some degree of heart failure. So we cannot bring the patient to theater as emergency to do cholecystectomy, either laparoscopic or open cholecystectomy under GA. This patient might perish under GA alone. So we manage in ICU, and then we perform a cholecystostomy to decompress the blocked gallbladder with a bag full of pus. And then patient recovered. The kidney recovered and the heart recovered. And then we proceed to the second procedure of clearing the bile ducts with ERCP and stenting. And patient recovered further, almost well, without any heart problem or renal problem. We subject him to laparoscopic cholecystectomy in the usual manner, but because of the intensity of inflammation, masking the safety signpost of laparoscopic cholecystectomy, we have to convert to open cholecystectomy in this case. And this patient has got a stent yet to be removed 1 month later. Just a CT scan to show how tempting it is to put the needle through the skin and muscle directly into the gallbladder here. Usually, if the patient is not ill, we will not do the percutaneous cholecystostomy. But because of the severe multi-organ deficiency, we need time before subjecting the patient to general anesthesia. So we managed to put a pigtail through the skin and the muscle here, avoiding the liver and the colon into the dilated gallbladder. This is what it looks like. You can see this is subcortical space. And we just avoid the liver, avoid the lung, and then of course we avoid the colon down there. And this is done by a surgeon with the help of radiologists who direct all these needle and tubes under direct ultrasound guidance. I understand that some radiologists do it themselves. The surgeon in the place might not be doing this interventional work. The radiologist himself or herself will do percutaneous insertion of drain into the gallbladder or anything into the abdominal cavity under imaging guidance, ultrasound or CT scan. They call themselves interventional radiologists. I don't know whether Dr. Fatima does that in Kelana Jaya. Case number 2, 50-year-old female with a history, family history. Mother has got ovarian cancer, presented with recurrent upper abdominal pain, quite severe. Clinically, there's tender in the right hypochondrium and Murphy's sign is positive. So clinically, this is a diagnosis of acute cholecystitis until proven otherwise. So ultrasound was done by our radiologist and confirmed this is acute cholecystitis, of course, with a uterine fibroid discovered as well. So this patient is quite well otherwise, so I subjected her to laparoscopic cholecystectomy. And at operation, the gallbladder appears big and firm to hard, not typical of cholecystitis. So we open up the gallbladder. There is a friable tumor inside the gallbladder. The final HPE come back as gallbladder adenocarcinoma. This is probably the first gallbladder adenocarcinoma in my entire clinical life since my practice. Before this, I just heard from other presenters in a meeting. This is the only case that I personally handle. So you can imagine, I've been doing surgery from 1994. This is the first case, how rare it is, but they do happen. This is her ultrasound preoperatively, and this was reported as acute calculus cholecystitis. Maybe Dr. Fatima can scrutinize further and see whether, alternative preoperative diagnosis is feasible in this patient rather than acute calculus cholecystitis. It doesn't appear like a typical gallstone, right? It's so big, but you can still imagine this is a big gallstone stuck in the gallbladder because of the smooth surface there. So basically, I just want to mention acalculus may mean two things: absolutely no stone, or there are microscopic crystals. So some acalculus gallstone are cholecystitis are false acalculus. They are there are stones inside there. What do we do with asymptomatic gallstones? 70% of them, This is very subjective. Just bear in mind, some of them are symptomatic, but they don't feel the pain. But the true asymptomatic one, you discovered them incidentally, okay? then make sure you do the full workup for the gallstone disease during liver function. And if they are deranged liver function, maybe the asymptomatic gallstone is not asymptomatic after all. It is symptomatic but unrecognized by patient. So some truly asymptomatic gallstone, but they are diabetic with other illness, we may consider cholecystectomy just in anticipation that they may develop further illness. Right? Yeah, don't forget about asymptomatic calculus cholecystitis. These are false asymptomatic patients. They don't have pain, but on ultrasound, you can see cholecystitis. So you have to treat them as cholecystitis. How to prevent gallstone? Yeah, all these modifiable factors, you can reduce them. And then in Malaysian context, the hemolytic disease is quite a significant health problem. So we may refer patient with whom we suspect thalassemia trait to hematology because of the commonness of the thalassemia genes. Okay, some patient after cholecystectomy, they have myths. You have to help them to alter those myths. And some of them present with biliary colic, and don't tell the patient that this is due to the cholecystectomy operation before doing the full workup or refer to the surgeon. Okay, we can go to the quiz now. Patients with thalassemia trait are liable to develop predominantly cholesterol stones. True or false? Can we get one? Can we get one or two answer in the chat box there? True, true. Okay, true. Oh, so many true. Okay, I underline the trait there. You know, it's not full-blown thalassemia. So usually, thalassemia trait, they just carry the genes. Phenotypically, they are normal people. Okay, so still normal people. What is the commonest cholesterol stone in the community? Is a cholesterol. What is the commonest gallstone? Is a cholesterol stone. So that is correct. Patient with a past history of right hemicolectomy has a higher risk of developing gallstone than the general population. A few answers. This one, you have, if you have surgical training, you can. In fact, I did mention it in passing, or maybe I didn't mention. No, okay. So this one, that's why we have to do some surgery in our training. Right hemicolectomy, we just excise 10 centimeter of ileum from the ileocecal valve, right? So, but statistics have shown that you need to excise 50 centimeter of ileum in order to predispose this patient to gallstone formation. Third question. A 40-year-old female presents with right hypochondrial pain, which radiated to the back. A physical examination reveals right hypochondrium tenderness. Okay. Number one, a normal total white cell count precludes the diagnosis of acute cholecystitis. True or false? Okay, right. It's false because you can make a diagnosis of acute cholecystitis on clinical findings alone, and of course with ultrasound. So a total white is not a sine qua non, they say, for the diagnosis of acute cholecystitis. Okay. Question number 2. A normal gallbladder with only sludge in the ultrasound precludes the diagnosis of acute calculus cholecystitis. This is the only, is a giveaway, I guess, and to answer. Of course, it doesn't preclude, right? A history of vaginal discharge is important in clarifying a diagnosis. What about this one? Number 3. Anybody wants to answer? It is important because pelvic inflammatory disease in the pelvis can spread to the right subdiaphragmatic area, causing perihepatitis. And this is a well-known description in the surgical textbook or gynae textbook of Fisk-Curtis syndrome. Number 4, a patient diagnosed with acute calculus cholecystitis on ultrasound without any bile duct stone or dilated ducts, but grossly deranged liver function test will eventually need pre-cholecystectomy ERCP. Oh, this is a bit of a mouthful. So I will repeat basically in terms of data. So this patient is diagnosed on ultrasound, acute cholecystitis. No bile duct stone were noted, no dilatation of the bile ducts. So basically the biliary tree are clear. In fact, you can add further. In fact, I can add further on this thing from my little experience. We proceed to CT scan. Even CT scan is clear, normal. There's no bile duct stone. Or even MRCP. MRCP was reported to be normal. But there is grossly deranged liver function test. Do we need to do ERCP before cholecystectomy? Any answer? We need to do a ERCP. We still have to clear the bile duct. See, the concept of microcrystal microlithiasis is real to a surgeon that handle these cases on the daily or weekly basis. Even that microcrystal, they are not discovered by ultrasound, by imaging. See, imaging is still an indirect view of things, you know. So those small, you know, microcrystal or microlithiasis is a misnomer. They are not that small to be microscopic in nature, but at operation we call them debris. But ultrasound or other imaging cannot capture them, and those debris can get stuck in the papilla. You can imagine the papilla is a potential opening. These are not a hole, big hole where the stone can just fall in and out easily. These are all potential opening which are closed by a valve. So even if you have a very small crystal get stuck at the junction in the lower common bile duct and the junction with the pancreatic duct, this is enough to cause pancreatitis, to cause cholangitis and cholecystitis. So even if all the imaging from ultrasound to MRCP are normal, but clinically they have biliary sepsis and liver function supports that, the surgeon will proceed to ERCP to clear the ducts. Okay, so we can go to conclusion now. Asymptomatic gallstone do not require specific treatment, but we have to be sure that they are really asymptomatic from our history and our overall evaluation. Biliary colic can be managed, can be clinically distinguished from other common gastrointestinal problems and potentially fatal cardiac problem, even by just by clinical evaluation alone, without any complicated tests. You know, that will include your ECG and ultrasound at your clinic. Non-complicated symptomatic gallstones can initially be managed as outpatient and followed up in clinic. You can manage this patient from your clinic without referring to the hospital, but they need to be followed up to discover any potential signs of serious progression to further infection. There is a role to play to modify some factors that cause gallstones, but like anything, prevention, when food is involved, it is difficult. It is easy said than done. Genetic counseling is controversial, but it may help to reduce the incidence of pigmented gallstones in the community. Thank you.
There's two questions in the chat box actually at 11:20 a.m. from Dr. Hamid.
Salam, would like to ask if GI losses possible to be additional presentation for GI losses. What is this? What do you mean? Okay, can Dr. Hanis expand on this? What do you mean by GI losses? Oh, vomiting and diarrhea.
Okay.
Okay, hang on. I'll come back here. What was the question? Oh, definitely. Actually, I simplify my presentation to not to mention the other associated symptoms with the pain. Of course, there are classical presentation of biliary colic, but the most important one is, of course, pain. But apart from pain, there can be vomiting, there can be nausea, but pain is the prime symptoms. If the patient come in with nausea and vomiting, the diagnosis of biliary colic is quite unlikely, unless you discover it on ultrasound, and ultrasound shows cholecystitis, like some patients who claim to be asymptomatic. That's the point when I say asymptomatic is a controversial scenario, because pain is a very subjective symptoms. Okay, but it is important dramatic symptoms, and from our surgical experience, most, if not all, significant gallstone related diseases would have pain as their prime presentation. So that's why I was concentrating on pain. And of course, they can get nausea, they can get vomiting, they can get headache, these are all associating factors.
And Dr. Witiwin, which antibiotic is the best for, and how long given?
Okay, antibiotics for cholecystitis is always empirical antibiotic. You see, this is the non-ideal situation where doctors have to prescribe antibiotic without knowing exactly what organism is causing it. But having said that, the gallbladder belongs to the GI system, and any GI infection, we will always give antibiotic that predominantly cover gram-negative. So you can choose any oral antibiotic that cover gram-negative. You can use augmentin, you can use ciprofloxacin, you can use cefuroxime. These are all good as a start. If some patient don't respond to antibiotic, the next thing to do is not to change antibiotics, is to refer to the hospital, because if initial antibiotic don't work to treat the early cholecystitis, you have to assume this patient have developed complex cholecystitis because of the failure of initial treatment.
And also, Dr. Naim, in healthcare KK setting, what medication can be given before transfer to tertiary center?
Oh, okay. Actually, there is a slide that I put up. Basically, you can give the antispasmodic, you can give PPI. This all can help the patient symptoms. Even if you want to entertain painkiller, give the, it's controversial to give painkiller in a patient with undiagnosed acute abdominal problem. But if the patient is under your care, you have been managing him as acute cholecystitis, and now patient fails to respond to your conservative treatment, and you are going to send the patient to the hospital. So the diagnosis is made. Basically, and you write in the letter that this patient has developed, severe acute cholecystitis, or known ultrasound finding, or even liver function test. So it will not confuse the surgeon anymore if the patient turn up to the hospital in a more relaxed position, in a more comfortable position. You can give painkiller in your clinic before going to the hospital. I know what oral antibiotic use, or that one?
That one same.
I answered already. Anything else? Antibiotic again. How long? 5 days to 1 week. If you want to really embark on conservative treatment, it has to be a standard duration, which is 5 days to 1 week, not longer, because you have to say it is a failure of medical treatment if you need to go further than 1 week. Gallbladder rupture, yes. You can imagine the progression of acute cholecystitis. Imagine like a balloon there. The gallbladder has turned into a balloon, inflamed balloon. So if there is empyema, the pressure is so high, and if we decompress, if we don't decompress the gallbladder like I did, on one of the cases that I presented, we put a cholecystostomy tube. That cholecystostomy is a decompression cholecystostomy. It decompressed the pressure and it removed the pus from the gallbladder. You can imagine if we don't do that and we can't operate the patient as an emergency because of the other multiple organ failure, the gallbladder will turn into a thin balloon and it will rupture. And that will kill the patient. So we will prevent that by doing a control rupture. Basically, percutaneous cholecystostomy is a control rupture. If you can put at that, you can say like that. And control rupture is good because patient is not worsened by that. Will that be okay? Or incidents? Well, very in the modern surgical practice, modern hospital setup, and a good primary care services that you referred patient timely. Very, very rare for gallbladder to rupture like that. A rupture during the operation is quite common. We call it perforation. They don't rupture in a massive way. They just got torn here and there during the procedure. That is quite a common situation during operation. And that one is of no consequence because we can wash the peritoneal cavity and and remove all the pus or bile.
Dr. Hamid, is that the last word for you to speak to all participants?
Thank you for listening to my presentation. I hope I have contributed some, new knowledge or revise your old knowledge. Thank you very much.